let's start talking about the normal ECG. Obviously, you are familiar with ECG because if you have an ECG machine, you do at least one ECG per month. So let's look at what is normal, and then from there, we can see what is abnormal by comparing. So we got this cartoon here that shows the depolarization of the various cardiac chambers. And as you know, everything starts from that green dot on the top in the right atrium, which is the sinus atrial node. That's the natural intrinsic pacemaker. So it's an area where the myocardial cells can depolarize spontaneously at a relatively fast rate compared to the rest of the heart. So for this reason, these cells are the director of the orchestra. They orchestrate the entire rhythm. And then you see these blue fibers here. These are the intra-atrial fibers that are fast electrical conduction cells, and they allow a fast conduction of this electrical depolarization to the yellow dot. And the yellow dot is the so-called atrioventricular node. The atrioventricular node is a structure between the atrium and the ventricle, which slows down the conduction, and then it will allow the coordinated contraction of the atria first, and then the depolarization and contraction of the ventricles after. So we see that from this yellow dot, then we got the depolarization, the electrical impulse that travels down the septum, and then on the two major branches, which is the left and right bundle branch, and then they divide the branch into very fine network of fast conduction cells that are called Purkinje fibers. They allow a very rapid conduction of the electrical stimulus along the myocardium, allow the complete depolarization of the chambers. And by doing that, we've got this deflection we record on ECG. We got the initial P wave, which represents the depolarization of the atria. Then we got the QRS complex, which represents the depolarization of the ventricles, and then eventually we got the T wave, which is the repolarization of the ventricles. And you would expect the repolarization to be the mirror image of the QRS, but in reality, the repolarization doesn't use the Purkinje fiber, so it's a slow process, and therefore it looks completely different, and the repolarization occurs from cell to cell. For this reason, the T wave, at least in our animals, not very much in people, can be positive, negative, biphasic. It doesn't really matter. It's not as significant as in people. The repolarization of the P wave is buried within the QRS complex, but is also a very, very tiny electrical event that even without the QRS complex, like for example, when we have a third-degree AV block, we don't really see it. It's very tiny, and therefore is not mentioned here in this diagram. And that's a very nice sinus rhythm. Sinus because it originates from the sinus node, and is very regular with every time a P wave, QRS, and T. And that's a very disciplined rhythm that we can see in these trays. However, in primarily healthy dogs, even more if they're young dogs, we see the sinus arrhythmia. And the sinus arrhythmia is where we still have a sinus rhythm, but is irregular. And as you can see here, the distance between two complex 2R waves changes during time. And it is primarily due to a phenomenon called respiratory arrhythmia. So in other words, when we breathe in, we have a lot of oxygen that needs to be delivered to the cell. So the heart rate increases to deliver this oxygen rapidly to the cells. Every single cell in the body will receive the oxygen from a cardiac contraction. But then during expiration, on the other end, we don't have oxygen, and therefore the heart slows down to save energy. Such a clever system. And I'm going to show you my own dog. Where is the dog, by the way? It's in the car. Oh, poor thing. Oh, you left it at Ralph. So that's our new puppy. And one day we were watching it, I said, oh wow, look at that. Look at the heartbeat that changes during respiration. When it breathes in, it increases. Look at that. Isn't it beautiful? And we did more than that. We recorded a phonocardiogram. That's a beautiful example of respiratory sinus arrhythmia. Now think about a whale or a dolphin. When they dive, they got certainly no oxygen. Their heart rate drops to 20 beats per minute. And when they re-emerge on the surface and they start breathing again, the heart rate goes up to 50, 60 beats per minute. Nature designed everything perfectly. But I kept saying dogs. How about cats? Do cats have sinus arrhythmia? Well, they do. They do. And actually, I must say that most healthy cats will display sinus arrhythmia, but only when they're left quiet. So if we record a 24-hour ECG, we can see what happens during night, when they're left alone and they can finally relax and sleep deeply. When they start sleeping deeply, then display sinus arrhythmia too. The reason is that sinus arrhythmia is exquisitely, vaguely induced. And therefore, when an animal is particularly relaxed, then the vagal tone increases and we see the sinus arrhythmia. But a cat coming to the practice, even if it looks very relaxed, they have a degree of anxiety all the time in a clinical setting. So we very, very rarely see it on physical examination. This is an example, but this was a very relaxed cat. And just to give you an idea, this, according to the description of the carer, this cat was going to fish every day on the river. It was passing by the house. It was trotting to the river, fishing. What a happy life. They always said that fishing is a very relaxing, I don't fish, but it's a very relaxing activity. So obviously it is for cats too. Right, so we'll try to divide now having seen the normal ones, I'll try to divide the abnormal ones in two major categories. And the first one is tachycardias, and then the second one is bradycardias towards the end. And then within the tachycardias, we will do a further stratification of different types of arrhythmias. There we go. Now the heart is beating fast. We call it tachycardia. So what would be your major concern in a patient with tachycardia? So you have to type here now. You have to type the word or the words that you want to use to express your concern in a patient with tachycardia. And we got no end. Oh yeah, we got one started typing, two. And if I move to the next slide, we can start seeing the answer. As soon as you send it, refill time, cardiac output, hypotension, cardiac output. So cardiac output is bigger because you got more people that answer cardiac output, hypotension. Okay, so I can see that hypotension, cardiac output are the two major concerns. And that's true. And to be honest, cardiac output and hypotension are strictly related because the blood pressure is the result of cardiac output times the total peripheral resistance. So in the, if we keep the total peripheral resistance then the same, then obviously cardiac output would be the major factor. Very good, very good. So why do we have reduced cardiac output with tachycardia? So I've got this diagram here, and I deliberately made this diagram dimensionless. It doesn't have numbers, all right? Because tachycardia is a relative concept. It's not a number. I mean, some people use numbers, but I'm against them. Because, for example, if I have a dog in the consult room with 60 beats per minute, is well within the normal heart rate. But if this dog is mad, is running around, jumping on and off the table, that 60 beats per minute would be not high enough for me. I would call that bradycardia, even if it's within the normal range. Vice versa, if I have a dog lying on the floor, not moving, very depressed, and has got a heart rate of 150, 150 is still normal in a dog at rest. But it would be too much for the dog that is not moving, not doing very much. So it's a relative concept. And therefore, we don't have a number here. But we do have a percentage in terms of cardiac output. Now, in this range, which is the physiological range, in the green area, despite the increase in heart rate, the cardiac output remains pretty much the same. Why is that? Because the cardiac output is the result of the stroke volume times the heart rate. So we increase the heart rate, but the stroke volume decreases because there is less time for the ventricles to fill with blood. And that is true up to this point, which is the end of the physiological range, where the heart is beating too fast, the ventricles don't even have time to fill with blood, and therefore the cardiac output drops quite dramatically. So too fast is not good, okay? So that is a cause of reduced cardiac output. But there is another concern that didn't come out in that, or perhaps I haven't seen it, is the very important concept of myocardial remodeling or tachycardiomyopathy. In other words, when a patient has a sustained tachycardia night and day for a number of days, then the myocardium will eventually fail. And in dogs is very well defined because dogs have been used in the past to create animal models for heart failure. So the way they were inducing heart failure was by doing fast pacing with an artificial pacemaker in order to pace the heart very fast for a number of days. And they found that if the heart rate is 180 beats per minute, night and day, that dog will develop systolic dysfunction within 2 to 3 weeks. So very important, if you have a dog that's got sustained tachycardia, you may end up with ventricular dysfunction. If the heart rate is 220, 230, as it might happen with some forms of tachycardias, the changes will appear just in 4 or 5 days. So that's why tachycardia is very important. We need to pay attention to it. And 24-hour ECG is the real gold standard test to do it, so you can see what happens during the day. And Holter recording nowadays is available to everyone. Some changes are, however, reversible because mechanisms of tachycardiomyopathy are several, but certainly the effect on the calcium channels is very important, but also the local ischemia, myocardial ischemia is very important. So if you catch these cases early enough, you can have a reversed cardiac remodeling. And this is a very old case. It's probably, I saw this one like 25 years ago, when I wasn't even aware of tachycardiomyopathy. This was a Springer Spaniel that presented with congestive heart failure with a very rapid ventricular tachycardia. We treated this dog with mexillitin at the time and converted into sinus rhythm. Same dog came back 3 months later, and there was the size of the heart compared to the previous one. So it went back to a completely normal heart in terms of size, but also in terms of function. We also see this in cats, and these are very old echo images. This is something I've done more than 25 years ago. Well, I'm showing my age, but probably you have already guessed that. So the quality, obviously, because at that time I wasn't probably particularly skilled, but also the ultrasound machines were not particularly good either. But that's the size of the ventricle in systole, nearly 2 centimeters. In a cat, it's a lot. 2 centimeters left ventricular diameter in systole is very, very increased. And the cat presented with this supraventricular tachycardia I think we are around 340, 350 beats per minute here. We managed to convert it into sinus rhythm again. And if I remember correctly, this was converted with digoxin, something that I would be quite scared to use nowadays. But at that time, we didn't have much else to use. And 3 months later, the ventricle, left ventricular diameter in systole went down to 1 centimeter, so half of what it was before. Isn't it amazing? Beautiful. So if we catch a tachycardia, significant tachycardia in time, and we've got a concomitant cardiomyopathy, we can reverse it. Right, let's start with a subgroup of tachycardias. And I like to divide it in three categories, because I think it's easier to remember this way. So we got the physiological tachycardia or sinus tachycardia, which could also be paraphysiological. So in other words, it's a physiological response to something that is pathological. Think about fever. Now, this is the time of the year where we get this nasty cold and flus, and the heart rate goes up with the body temperature. We have irregular narrow complex tachycardia. Narrow complex means that the length of the QRS complex is less than 70 milliseconds in dogs, less than 40 milliseconds in cats. But we very rarely measure it. We just have a subjective assessment. If they're spiky, it means that they are narrow. And then we will see the difference when we talk about the Y complex tachycardia. But they can be irregular or regular. And typical irregular tachycardia, non-complex tachycardia, is atrial fibrillation. Probably actually one of the most common arrhythmias, tachycardias we see in dogs. We can have also irregular atrial flutter, but you can see atrial flutter also comes under the regular. So it very depends on the AV conduction. We're going to see it when we talk about atrial flutter. But regular tachycardia, atrial for sure, is a very regular tachycardia. Could be focal or multifocal. We tend to see more focal than multifocal, but both are possible. We can have junctional tachycardia, or we can have accessory pathways. Accessory pathway, we're going to see in more detail, are conditions where the electrical impulse, rather than dying naturally after the depolarization of the ventricles, goes back into the atria using an aberrant bundle of tissue that has a fast conduction, and therefore the impulse goes back to the atria and reignites the circle. These are, again, regular tachycardias. Right, now let's start with sinus tachycardia. Which of the following is a feature of sinus tachycardia? It's a heart rate below 180, a long PQ interval, a warming up and cooling down, meaning the heart rate goes up and down, or the presence of tall P waves. It's actually a very easy question, so just follow your instinct and you will get it right. Let's see, 3. Or maybe the ladies were impressed by this very good-looking cardiologist that works with us at the Ralph. Yeah. And we got Sergio's good-looking too. But this guy here is actually made with artificial intelligence. Right. Okay. We got 7. Half of you have. Exactly. So we do have a warming up and cooling down phase. In other words, the heart rate goes up progressively and then reaches the top heart rate, and then when it turns off, it cools down progressively too. So we can see that very nicely on Holter, on 24-hour ECG. This dog is going out for a walk. Okay, so the heart rate is a nice sinus arrhythmia, and then slowly gets faster and faster and faster until it becomes very regular. But we can still see all the features of a sinus rhythm, P, QRS, T, all together in a nice disciplined fashion. So that's the warming up, and then we got the cooling down here. There we go. So that's the dog that is relaxing after the exercise. Cooling down phase takes a little bit longer than the warming up, and that depends also on the level of fitness. Now, I know that my resident is very fit, he does a lot of sport, so if he goes running, his heart rate will go up quite nicely, and then it will go down pretty rapidly too. But if I go running, since I haven't exercised for ages, then my heart rate will go up very, very fast and will stay fast even after I stop running. So that depends a lot on the fitness of the individual. Why do I say that? Because if we are listening or we are recording ECG, and we are lucky, and we make a diagnosis of tachycardia, we're lucky to see these changes that are gentle and progressive, then we can make a diagnosis of sinus tachycardia, even without a Holter. But sometimes we do need a Holter to clarify this question. So what's the difference between a sinus tachycardia and a supraventricular tachycardia? Supraventricular tachycardias, by definition, have a very sudden onset and a very sudden offset. And that's an example here. We got this Labrador with a nice sinus rhythm, and all of a sudden we got this battery of very fast beats. They start with 3 ventricular ectopics here, and then it becomes like a narrow complex tachycardia. You see, it's faster, but it looks very similar to the one above, and then stops very suddenly too. Okay? So sudden onset, sudden offset, typical of supraventricular tachycardia. But if you want to be very pedantic, you can also, especially because you all have digital ECG machines, 100% of you can actually use the digital calipers to measure the RR interval. And there are slight changes. Although it looks subjectively very regular, there is a little bit of variation from beat to beat, even with a heart rate of 180, 170 average here. And something you don't see with supraventricular tachycardia. That tends to be metronomically regular. And the same applies to cats. There we go. We got a cat here with hyperthyroidism. 250 beats per minute is not particularly fast, but still compatible with a tachycardia in the cat. And here we see the peak, your ST. Again, we are happy to call it sinus tachycardia. So as I said, it could be physiological, exercise, the one I mentioned, but also fear, excitement, pregnancy. These are all physiological conditions. Paraphysiological, fever, respiratory distress, pain. Pain is actually very important. The fastest sinus tachycardia I've ever seen were puppies primarily with bone fractures. So after a road traffic accident, the pain was so important that was causing a very, very fast tachycardia. And then we go other pathological conditions like hypovolemia, anemia, heart failure, hyperthyroidism, pheochromocytoma, and sepsis. The only difference with pheochromocytoma, perhaps, that's probably the only exception where you have a sudden onset and sudden offset, because that is in relation to the release of catecholamines by the tumor. But also iatrogenic causes are important: ketamine, atropine, thyroxine. We give thyroxine sometimes in good faith, thinking we're dealing with an hypothyroid patient, but the patient is perhaps a euthyroid sick syndrome case, and therefore we may end up causing a sinus tachycardia. In case of doubt, as I said, Holter is a fantastic option, or there are some portable monitors, and they cost less than £100. They can be used even by the carer at home. So you can say, well, your dog is, or your cat is quite tachycardic here. Let's see what it does at home when he's relaxed in his own environment. And that's a very good way, much cheaper than a Holter, to do this discrimination. Or, that's what my mentor used to say, just buy a very cheap stethoscope and give it to the carers, and they can count the heartbeats at home. Some may be good, some others may not be that good. So never really trusted this system 100%, but certainly is another idea. Now we're going to move to the irregular rhythms, but before I would like to know which of the following is not a feature of atrial fibrillation. In other words, they're all features of atrial fibrillation except one. Narrow QRS complex, prolonged PQ interval, irregular heart rhythm, and pulse deficits. We got 2 people. Yeah, because we're going to see the most common arrhythmia we see in practice. Ooh. Yes, sorry, I was thinking about the pause. Yes, absolutely correct. That's not a feature, but they're all narrow QRS complexes. They're all irregular. It's an irregular rhythm, and we do have pulse deficits. Very good. So that it is. Atrial fibrillation. So the cause of atrial fibrillation is the presence of micro reentrant circuits within the atria, like little tiny vortices of electricity that are running in a very chaotic way. And therefore, we don't have P waves anymore. Instead, we got the so-called fibrillatory baseline. And all these little tiny movements here are electrical activity of the atria. Easily 500, 600 beats per minute. But fortunately, we got the AV node blocking many of them, and therefore, only when one of these chaotic currents arrives at the level of the AV node, and the AV node is in an excitability situation, not in a refractoriness, then that impulse will go down. But will go down following the normal electrical conduction system. Therefore, the QRS complex will be narrow, looking like a normal QRS complex. And because it's so chaotic, it's irregular. Now, this is a case of so-called lone atrial fibrillation or slow atrial fibrillation, which is not very common. We see sometimes this in giant breeds, but as I said, not very common. What we see more often is this one. Right, now I feel a little bit less comfortable in diagnosing atrial fibrillation because I don't see the fibrillatory pattern on the baseline. So I've got the mantra from my mentor that taught me that if it's fast, if it's narrow, if it's irregular, it's atrial fibrillation until proven otherwise. There are no other tachycardias that can be so irregular like atrial fibrillation. And that works 99% of the times. And so if you see something like this, you got your diagnosis of atrial fibrillation. When we measure the heart rate, we tend to do it always as an average heart rate, especially when we have a degree of irregularity. Because if you measure the instantaneous rate, which is what some digital ECG machines do for you, you may get a slow heart rate here, but then a very fast heart rate here, for example. So it keeps changing, and it's not easy to understand. But it's the average very important, especially when we discuss treatment. And I don't know if you were also last month at the Ralph when we talked about heart murmurs. Probably not. There's another group here. You were, yeah? And I recorded this video when I put the surgical shoes in the washing machine. We ended up with this chaotic sound, which is exactly the sound of atrial fibrillation. Right? Have you ever tried to wash your yeah, well, I'm sure you do, right? And that's, I think, a very nice way nice analogy to use. Now, which of the following is an important requisite to produce a sustained atrial fibrillation? Now we're going to do something a little bit more challenging here. You can answer more than one. You're allowed to answer more than one here. You got a large left atrium, a large right atrium, atrial premature complexes, increased parasympathetic tone, or increased sympathetic tone. Okay, it could be 1, 2, 3, 4, 5, or all of them. So you can choose whatever you want. Let's wait until we got at least 5. I appreciate it's a difficult question. Right, let's see. Oh, 10 all of a sudden. Fantastic. Let's have a look. Enlarged left atrium, correct. Enlarged right atrium, correct. Atriopremature complexes, correct. Increased sympathetic tone is also correct. Unfortunately, we can't see the others, but all these are features of atrial fibrillation, or not features, but requisite to produce a sustained atrial fibrillation. And that comes from a concept that has been beautifully described by Philippe Coumel, a French cardiologist. French cardiologist is pretty good. And certainly Coumel was one of the top cardiologists. He died only a few years ago. And he said that, or he proposed this theory where you can have sustained atrial fibrillation if you have all these 3 elements. You have a substrate, you have modulating factors, and you have triggers. Now, we see atrial fibrillation primarily, or more commonly, in dogs with mitral valve disease, and they have big left atrium. So big, I wrote left atrial enlargement, but it's exactly the same on the right side, so it could be a right atrial enlargement. And then we've got, as a modulating component, we got the autonomous nervous system, either with increased sympathetic tone or with increased parasympathetic tone. Both can increase the probability of having a sustained atrial fibrillation. And then the trigger is a premature complex. In this particular case, an atrial premature complex. So if you have all these 3, then you got sustained atrial fibrillation. And it's important to know this because if you are, for example, screening or examining, evaluating a patient with mitral valve disease, and you see that there is a big atrium on ultrasound, and the ECG shows atrial premature beats, you know that that dog will soon have also an increased sympathetic tone as soon as he enters heart failure, or maybe he's already in heart failure. Then you got all the elements for a possible atrial fibrillation. And we look at it very carefully, because if we have a patient like that, rather than say, come back in 6 months, we say, let's make sure that we check at least monthly what the heart rate is doing, because that dog may develop atrial fibrillation. And if they develop atrial fibrillation, it's usually fast. So we need to intervene quickly to reduce the heart rate, to avoid the risk of tachycardiomyopathy. Does it make sense? Excellent. Right. I've got beautiful videos here from an American colleague called Sidney Moise, a real expert in arrhythmias. And here, they were doing a pericardectomy. Look at the atrial fibrillation, how the atria are contracting compared to the ventricles. Isn't it beautiful? It's beautiful to see on ECG, but even more convincing when you see it on a heart beating in front of you. So again, you remember the hemodynamic aspect of a tachycardia and the cardiac remodeling aspect. We do have problems here because of the fast heart rate, of course, but also we have the absence of the atrial kick. This is just a vibration of the atria. They're not actually contracting, they're not contributing to the ventricular filling. Then we have, obviously, atrioventricular asynchrony, but there is also an increased risk of thrombi. Now, this is very important in people. As soon as a human patient is diagnosed with atrial fibrillation, they will put that patient on anticoagulants for this problem here. Or they can consider an auriculectomy, they can consider a deployment of a plug in the auricle to reduce the risk of clot formation. How about dogs? We don't have the same knowledge. I'm not saying the same incidence, but we don't have the same knowledge. Although a few years ago, we published a paper on the number of the cases of cardiac sudden cardiac death in dogs with atrial fibrillation. And we believe that most of these cases are cases of clot formation, pretty much like it would happen in a cat with cardiomyopathy. So these clots may then travel, can dislodge and travel in the aorta and perhaps go and occlude one of the carotid arteries, causing sudden death. But don't forget also the cardiac remodeling, right? This is a dog that is having an atrial fibrillation, and you see how dilated the chambers are. Now, you can say, well, is it the chicken or the egg? Are they in atrial fibrillation because the heart is dilated or vice versa? But because we follow them over time, we know that in this case was the tachycardia that caused the ventricular dilation. So how do we treat atrial fibrillation? Well, we've got two options. Well, three. You can decide not to treat if it's not particularly fast, and sometimes we do that. But if we decide to treat, then we have two options: rhythm conversion and rate control. Now, rhythm conversion is something that we don't do routine. We can't do it. We got all the equipment and expertise to do it, but we don't do it because we know that because of the underlying cardiac remodeling, there's already dilated atrium, etc., they will return into atrial fibrillation within hours, days, or weeks, but they don't last much longer than weeks. So it's an electric shock that will stop the atrial fibrillation and will restore the sinus rhythm. We've got videos to show you. So we have instead, we use the pharmacological approach that will reduce the heart rate. If we reduce the heart rate, we improve the hemodynamics, and we reduce the risk of tachycardiomyopathy. And rhythm conversion is also quite brutal, right? So again, these are images from Sidney Moise. The dog needs to be in general anesthesia. And why do I keep saying dog? Why don't I say cat? Why do you think that cats are not predisposed to atrial fibrillation as much as a dog? They're much smaller, right? So they've got much smaller atria. So it's not the proportion of the size of the atrium with the body, it's actually the surface of the atrium itself. So in other words, in horses, it's very common. Whales seem to live most of their life in atrial fibrillation. Giraffes too. Not sure about elephants, but I would imagine so. And it's almost impossible to induce atrial fibrillation in a mouse. You can do with very sophisticated electrical stimulations, but otherwise they will never develop it. So that's why I keep saying dogs, okay? So general anesthesia, and then this dog will receive an electroshock. It's quite brutal, as I said.
All right, just empty. I'm not doing anything so you get clear. Okay, everybody clear, here goes. Sprint it.
Right? They literally jump off the table, and because of the muscle contractions that are associated. But I've got also the conversion to show you on the screen, which is lovely because if you have met Sidney Moise before, you know how enthusiastic this cardiologist is.
You tell me where to now. Nice. Oh, we have time to spare. Yes, we do. Wait. Yeah, yes, we do.
A lot of excitement. Probably this dog was back in atrial fibrillation an hour later, but there we go. That's cardioversion for you. Are we concerned about not restoring the sinus rhythm? Not really, because we do see massive improvement in cardiac output, and we are sort of reassured that if we reduce the heart rate, average heart rate, we reduce the risk of tachycardiomyopathy. But this is a study they've done in 1,300 human patients, where they compare the outcome of patients receiving pharmacological control, heart rate control, or cardioversion. And you can see that the survival is exactly the same. So in people, the reason why they still do cardioversion is because it's a very uncomfortable feeling. Fortunately, I never had it, but I I've got friends with atrial fibrillation, and they told me it's a very unpleasant feeling. And one of the major causes for hospitalization because of this feeling of palpitations that are really, really unpleasant. So how do we control the heart rate? We have a very, very successful combination of drugs, and it's a combination of digoxin and diltiazem. We use digoxin at a very low dose, and that's 3 microgram to 5 microgram, although we should say 0.003 to 0.005. That's because that's how they sell the drug, so to avoid errors in the calculation, milligram per kilo twice a day. And then we should, we always do actually, but we should measure the digoxin level 5 to 7 days after treatment, but always 6 to 8 hours post-pill, because we want to measure the trough level of digoxin in the plasma or serum, not something in between. So it has to be 6 to 8 hours after. And we combine it with diltiazem, 2 up to 5 milligram per kilo twice a day in a slow release or modified release formulation. When we measure the digoxin level, the therapeutic range should be 0.5 to 1.2 nanogram per ml, which corresponds to 0.65 to 153 nanomoles per liter. So it depends on which units the lab uses. And I don't know, I think that most labs now use this range. It was a campaign that I fought 10, 15 years ago, and I managed to persuade these labs to change their range based on the publication of Anna Gelser and colleagues in 2009, where they found that that is the therapeutic range. But before they were going up to 3 nanogram per ml as a normal range. But they were all toxicity cases, digoxin toxicity. They were vomiting, they were having conduction abnormalities. So now we are much more conservative in the amount of digoxin we give. But then how do we know if it's working or not? Well, we should Holter these patients. And the target heart rate should be less than 125 beats per minute as an average throughout the 24 hours. And that's also supported by this study that pretty much reflects what Anna Gelser said in 2009. And again, they said that the optimal target mean heart rate should be less than 125. Right, if you remember, we were talking about flutter earlier. That's not very common, so I'm not going to spend too much time on flutter. Somehow it's similar to atrial fibrillation, but these are macro circuit. So there are, the video stopped, but there we go. You can see the diagram here. It's a natural activity that is, however, much faster than a normal atrial activity. So we're talking about around 300 beats per minute. And then depending on how many of these waves are blocked by the AV node, we got the associated ventricular rate. So it could be irregular or irregular for this reason. Here we got an irregular one, because here we got 1, 2, 3, 4 atrial activities per QRS complex, but then here we got only one. And the shape of the P wave is also quite peculiar because it looks a so-called sawtooth shape of the P wave. So in this case, the atrial flutter would be irregular. But that's from Sergio case from last week. I just remember that. And here we got a very, very irregular. But because it's 1-to-1, you can see that we are around 300 beats per minute. So that's exactly the same number of cycles in the atria is transferred down to the ventricles. Not an easy diagnosis, right? What you can do here, you can do a vagal maneuver. We're going to talk about that in a minute. Or, easier, you can do a 24-hour ECG. And then if you follow this rhythm throughout the day, you might be lucky, like in this case, to see when the rhythm stops. And then you can see that it was an atrial flutter. right? Typical sawtooth appearance of these waves. But the other regular supraventricular tachycardias are the atrial tachycardia and the junctional tachycardia. Let's start with the atrial tachycardia, certainly more common than junctional tachycardia. And you see that it's pretty much like a sinus rhythm. The only difference is that the pacemaker is not the natural pacemaker, is not a sinus atrial node. It's another cell in the atria that decides to be the leader, right? So it starts depolarizing at a much faster rate. And this is usually when you got a atrial disease or an atrial dilation. And they can easily reach 250, 260 beats per minute. So it's a very, very rapid rhythm, which is something you would not easily see with sinus tachycardia. Okay? So although it looks like a sinus tachycardia, it's not because of that. And then you see we got a rapid interruption and restoration of the sinus rhythm. But junctional tachycardia is rare, as I said before, is when you've got a cell near the AV node that becomes the leader. So you got a wavefront going down the AV node, the bundle of His, giving this narrow complex appearance. But also you got a wavefront going upward. But for this reason, you don't really see a P wave, or sometimes the P wave may appear dissociated with the QRS complex. And there is a big debate whether the atrioventricular dissociation and the junctional rhythm are associated or are different entities. So even the big experts do not have a very precise answer to that. And then finally, the accessory pathway. We got an accessory pathway here. In the dog, you see that if I can use the laser pointer, that's easier. You see that the wavefront, rather than dying at the end of the cardiac cycle, it goes back to the atria using this abnormal bundle of conduction tissue that will allow a retrograde conduction. And by doing that, we'll reignite another cycle, in the atrium. And it can be very rapid, like in this case. The sudden onset and sudden offset is because this one can switch on and off depending on the refractoriness or excitability, which is often heart rate dependent. And here we got another example in a cat. That's a reentry or an aberrant pathway in a cat at around 350 beats per minute. I don't have the onset and offset, but I would imagine it would be very, very abrupt. Right, we mentioned the vagal maneuver. Vagal maneuver basically is a technique that we use to increase the vagal tone and to see whether we can interrupt the tachycardia. Because if we are successful, the interruption of the tachycardia will tell us, in the majority of cases, which type of tachycardia we're dealing with. And there is the easier one is the ocular pressure, so you press on the eyeballs. Well, you press on the eyelids, pushing the eyeballs inward, and there is ocular vagal reflex that will increase the vagal tone. I don't have much luck with this, and dogs and cats don't really like it. So very often they react before you obtain the result. Or you can try the carotid massage. Carotid massage is, in my opinion, much more successful. Basically, you press on both sides along the jugular groove to press the carotid arteries that are underneath. There are the baroreceptors under there that will stimulate a vagal tone that might interrupt the tachycardia. And the last option could be a chest thump. Basically, you punch the chest on the left side, the level of the cardiac area. It has to be a pretty hard thump, something like this. So if you do it, don't do it in front of the carriers. Or explain what you're doing, all right? Because it might look a bit weird if you start punching their dog. But in this case, we couldn't stop this tachycardia with the ocular massage or the carotid massage, the ocular pressure, the carotid massage. So we did a chest thump, and you can see we moved from this very rapid tachycardia to a sinus rhythm. So if we have this very abrupt change, it's more likely to be a supraventricular tachycardia than a sinus tachycardia. So what do we do with these arrhythmias, with all these tachycardias? Well, if referral is an option, then you can consider an electrophysiological study that has that can provide the identification of the abnormal source of the rhythm, the focus of the arrhythmia, and that focus can be eliminated with radiofrequency ablation. So it's a high-frequency radio signal that will burn the myocardial tissue and destroy the abnormal cells. This study has been around for many years now, and I think the pioneer in veterinary medicine is Roberto Santilli here. Sergio was one of his pupils, and I used to follow him when he was doing all these studies. That's what you see here on the screen during the procedure, because you got many, many channels to understand exactly where the abnormal bit, the abnormal cells are. Or the other option is to refer to Davis here, because Roberto Santilli is in Milan, and the other option is to refer to Davis referrals or Davis specialists, where Pedro Oliveira, I think he does once a month these procedures, and is another very clever guy. So as far as I'm aware, in Europe there are only these two centers. There may be more coming in the future. There was Edinburgh for a while, but then they had a few technical issues, so they stopped the program approximately 10 years ago. So that's one option. Money-wise, I'm not even sure, but I think at Davis is around £8,000. Does Sergio, am I correct? Around 8,000? Yeah. Yeah, and Roberto Santilli is much cheaper. How much is Roberto? 5,000 for?
No.
3.
It was 3,000.
3,000. So I know people that decide, well, if it's 3,000 in Milan, I just go there, I leave the dog there. They will also pay for my trip and the shopping in Milan, which is the city of fashion. So some people, when we offer these two options, decide to go to Milan rather than going to Davis. But there we go. So you know that this is a possible option. Otherwise, if referral is not an option, then we have the antiarrhythmic drugs. Now, antiarrhythmic drugs are a bit of a mystery. They may work in some patients, they may not work in other patients, despite they have the same abnormality. And so it's a bit of, how do you say, lucky dip. So you can try, and it may be lucky or may not be lucky. So with supraventricular tachycardia, so narrow complex tachycardia, we normally start with diltiazem and digoxin, very often in combination. If that fails, we try beta blockers, although personally I skip this one because I never had luck with beta blockers. And then we move to the class 3 antiarrhythmic drugs, Sotalo or amiodarone. But important is every time we use an antiarrhythmic drug, we need to Holter. If we don't Holter, it's very risky because every antiarrhythmic drug can be pro-arrhythmic. So we may make the arrhythmia much worse. And therefore, every time we use an antiarrhythmic drug, we need a Holter also to see whether it's working or not. Because if it's not working, then we need to change drug. So we move to the next most successful one. How about cats? Exactly the same. The only thing is missing here is amiodarone because I do not have experience at all with amiodarone. There are 2 or 3 anecdotal reports from the States, but I'm not aware. Did you use amiodarone with Roberto Santilli? No, in cats.
No, in cats.
There we go. You couldn't say yes because otherwise you were destroying all my train of thoughts. Right, let's move to the Y-complex tachycardia. As you can see, Y-complex tachycardia have this bizarre Y shape. They're no longer spiky. And And the reason is that the conduction is no longer, in the ventricles, is no longer through the Purkinje fibers. The conduction is from cell to cell, so it takes much longer. If it takes longer, on the ECG will appear wider, because the ECG is simply a diagram of amplitude versus time. And these arrhythmias here originate from a new leader that, rather than be on the upper chambers, is on the lower chambers, is on the ventricular wall. And it can be on the right side, can be on the left, could be on the interventricular septum. It doesn't really matter. They can all produce ventricular tachycardias. But the rate is very important, because if we see something like this, 100 beats per minute, we just smile. It's not causing any problem. The only thing you have with this slow ventricular tachycardia, also called accelerated ventricular rhythm, but slow ventricular tachycardia gives exactly the same cardiac output. You only miss the atrial contribution, which is at rest around 10%. So not a big deal. The dog will not even know it's got this rhythm. But beginners may panic when they see it, because it looks scary, it looks different, and they start giving drugs. Don't touch these patients. 99% are not even cardiac. This is a reflection of an underlying respiratory or gastrointestinal condition, or a trauma. Chest trauma is the other very common cause. But then when we see another rhythm like this, 100 beats per minute, but you see the complexes change, it becomes so-called polymorphic, we start thinking, it means there are at least two foci in the ventricles causing it, not just a single one. So these are patients that perhaps we do nothing, but we monitor more closely. Then we may have a faster rate, 200 beats per minute here, right? 200 beats per minute depending on how familiar with these abnormalities. We try to be quite relaxed. We look at this, we check the pulses. Pulses are good, we just sit and wait. Other people will intervene, okay? And I'm against interventions if are not needed. But when we move to something at 320 beats per minute like this one in a dog, that's pretty fast. That will compromise the cardiac output and will certainly increase the risk of tachycardiomyopathy, but also will predispose to sudden cardiac death, which you almost never have with a supraventricular tachycardia. Supraventricular tachycardias are mostly compatible with life, but this one can cause something worse. Oops. There we go. So is a wide QRS complex, so more than 70 milliseconds in a dog or 40 milliseconds in a cat, always compatible with a ventricular rhythm? We can say yes, no, or I don't know. I can see the tiredness coming. The first slide was like 15 answers in 1 second. Now, we're struggling here. Let's have a look. That's correct. Now we're in trouble. I love democracy. 50-50 here. Yes or no? Well, yes, yes, ventricular complexes are wide, but you can have wide QRS complexes that are not ventricular. They are the so-called bundle branch blocks. Look at the right bundle branch block. It means that the right bundle branch, which is here, is interrupted, which means that the left will depolarize rapidly, but the right will depolarize cell to cell or later. So it takes much longer. So you still have a sinus beat, but the morphology of the QRS is completely different. So P, QRS-T, P, QRS-T. So that's the typical right bundle branch block. We see very commonly in dogs, sometimes in cats too. Sometimes they're associated with congenital defects, ventricular septal defects, pulmonary stenosis. Sometimes we can't identify any possible cause. And while in people, they do the resynchronization therapy or biventricular pacing, because it compromises the cardiac output, it doesn't seem to be an issue in our patients. So we don't actually intervene for these cases. Sometimes we actually induce it ourselves when we do procedures, catheterizing the right ventricle. When we go inside with catheter in the right ventricle, sometimes we incidentally damage the AV node, and we don't actually do anything. Sometimes they go back to normal on their own. Vice versa, if the left side is blocked, the right will depolarize first, and then the left. And therefore, we have like a normal sinus rhythm. As you can see, peak or ST, but complexes are wider and bizarre in shape. Okay, so always look for the P way to discriminate between ventricular rhythm and bundle branch block, because one is potentially dangerous, the other one is relatively benign. And also you need to become familiar with the terminology. We mentioned already the polymorphic, and then we have these patterns. So the pattern with a normal beat followed by a QRS complex, and then it repeats over time, is called ventricular bigeminy. Two normals and one abnormal is called trigeminy. Gemini in Latin means twins, and that makes perfect sense. Trigeminy means three, well, twins and another brother, right? So they got the trigeminy. Well, we don't really know what the clinical significance is of these rhythms. Certainly there is a reentrant circuit, most likely within the myocardium. And the human cardiologists are super relaxed with this. I had a Holter myself a couple of months ago, and I had hours of bigeminy. They smiled. I was worried, they smiled. Okay, so just to give you an idea. Because if the cardiac output is not compromised, you've got still good pulses, probably nothing to be worried about, but certainly something we need to monitor. Ooh, when I see something like this, that's scary, right? This is a very scary Y-complex tachycardia, and you can see the feature is Y-complex, they keep changing in height. Tall and short, tall and short, tall and short. And a French cardiologist, forgot his name now, but he named this rhythm the torsade de pointe, that we say pointes, which is the point are the tip of the shoes of a ballerina. Right. When a ballerina spins, do you like ballet? They were doing it next door. We could have joined them for talk about the torsade. When a ballerina opens and closes the arms during the spinning, the speed changes. So obviously this cardiologist was very attracted by ballet that he named this abnormality, the torsade de pointe. And I recorded this video because it's almost Christmas, right? And the Nutcracker is the quintessential Christmas ballet. And I love ballet too, so there we go. Look at the tips of the shoes of this ballerina. Beautiful. And did you see that, how she changes the speed? Amazing, amazing. Sergio can do even better when he does the dancing in cardiology. Tomorrow, we need to give a demonstration tomorrow. Why is it scary, torsade de pointe? Is because it precedes ventricular fibrillation, almost inevitably. Ventricular fibrillation is a loss of rhythm completely chaotic, and precedes death, asystole. So as soon as you see a rhythm like this, you need to intervene immediately with electrical defibrillation. Now, electrical defibrillation can restore the sinus rhythm, but is not very successful in veterinary medicine. Why? Because we see mainly dogs with cardiac disease with that end up with ventricular fibrillation. Some exceptions, something goes wrong with anesthesia, they're young puppies or kittens that are going for surgery and something goes wrong, then it can be successful. By my experience, I've got only 10% of successful defibrillation. And of this 10%, only 10% will then eventually go home. So that means 1%. It's not like ER. Every time they defibrillate on the movies, they get back into sinus rhythm. Always, don't they? And that's what we see, actually. This dog presented with a rapid ventricular tachycardia and then starts here with a torsade. Right? You can see the torsade we saw earlier, tall and short, and then it starts in ventricular fibrillation. So by the time we arrive with the defibrillator, at this point we give the shock, and we manage to convert the rhythm from ventricular fibrillation to a systole. But that's not the type of result we wanted. We converted the rhythm the wrong way. And then we gave another shock. We had 2 random complexes, and that's it. Unfortunately, that's what we see. So not as successful as in people. So we use drugs sometimes to prevent it. So when we got a ventricular arrhythmia that is severe enough to cause concerns, we can start by giving lidocaine IV. And then we can continue the medication with oral treatment. Could be a class 3 antiarrhythmia like sotalol or amiodarone, or mexilitine that was unavailable for a few years, but now you can get it from the compounding pharmacies. Was it Summit, is it? Summit is called mexilitine. So you can find it. But remember, every time you need to Holter, because if you don't Holter, you don't know whether you can cause more damage or whether you don't have a significant result. Now, here is Heidi in ICU with Kim, and they are converting this rhythm with lidocaine.
Someone told me that it's him. It's the I can't see the rhythm. Just do the meter. Is it meter?
Similar to Sidney Moise in a way, less excited.
By Germany?
Look at that. Beautiful. Beautiful conversion back into sinus rhythm. Remember to give it slowly. The bolus needs to be given over a minute in dogs, at least, and 2, 3, 4 minutes in cats. Because if you go too fast, then you may end up with very unpleasant complications, certainly seizure-like activity and collapse, vomiting, diarrhea, etc. Right. Do you know any non-pharmacological intervention to control ventricular arrhythmias? You can type if you want. Apart from the defibrillation, of course. All right, so not even probably they're not voting deliberately, my people here. Anyway, omega-3 fatty acids. You were typing it. Too slow. Right? Omega-3 fatty acids in the form of fish oil are amazing antiarrhythmic. It represents an amazing antiarrhythmic treatment, especially when it's a fat fish. So you can even give fish like sardines, anchovies, salmon, tuna. They're all rich in omega-3. But omega-3 coming from a vegetable source, unfortunately, doesn't have the same property. And we don't know exactly why, perhaps something else apart from the omega-3 that is in the fish oil. Regardless, this is a very interesting story because in 1940, there was a Finnish study that compared the prevalence of coronary artery disease in the Eskimo people in Greenland. And they compared them to similar population in Finland living under the same conditions. And they found that the prevalence of coronary artery disease in Greenland was 4 times lower than in Finland. And they realized that the Eskimo people in Greenland were on a diet that was maximum 2 to 4% in carbohydrates. while the Finnish people were on 40% carbohydrates. And then eventually they realized 2% means more fish compared to the Finnish people. And so after the war, when even the Eskimo people in Greenland started eating like the so-called Western countries, all of a sudden the prevalence of coronary heart disease matched the prevalence in the Finnish population. So they said, it's the fish that makes the difference. And indeed, a lot of studies came out after that where they compared the control diet, rich in carbohydrates, with the so-called Mediterranean diet, which is rich in fish. And what they found that the Mediterranean diet drops significantly all the causes of death, cardiac mortality, non-fatal myocardial infarction, and even cancer. So if we are affected by a cardiac disease, our cardiologists now, following the guidelines of the American Heart Association and American College of Cardiology, will suggest to have a fish meal at least 3 times a week. And if we don't like fish, we can get the capsules, which mask the taste. So they tried that in dogs. There's a nice study published by this Freeman's group, and they used boxes with the arrhythmogenic cardiomyopathy. And they measured a Holter, they recorded a Holter before treatment, and then they recorded another Holter after treatment by giving omega-3 fatty acid in forms of fish oil. And there was a reduction in the number of VPCs, of ventricular complexes, but also the complexity of the ventricular arrhythmia. But the same results were not particularly clear, at least, with flax oil, which is still rich in omega-3, but is not of fish origin. We use this a lot, and we do have a lot of dogs that we can control just with fish oil. Sometimes the arrhythmia disappears completely, sometimes it's reduced dramatically. But even here, we need to consider Holter, both in dogs and in cats. Very briefly, in the last 10 minutes, we can talk about bradycardias. Remember what we said before? If we reduce the heart rate too much, then the cardiac output drops. Because when the heart rate drops to the point where the ventricle cannot dilate more than the maximum compliance, then the cardiac output will drop. So too slow is not good either. And similarly, we can have myocardial remodeling because the continuous stretch of the myocardial wall in diastole can potentially damage the myocardium. Right, let's look at some forms of bradycardia. We start with sinus bradycardia, identical to a sinus rhythm, but slow. And slow, remember, we need to look at the situation, but it's not like a slow sinus arrhythmia. This is metronomically regular. So that's sinus bradycardia. Otherwise, it's sinus arrhythmia. And sinus bradycardia is usually associated with hypothermia, CNS disturbances, usually head traumas, hyperkalemia, hypo. I caught you, distracted, naughty boy, hypothyroidism. Okay, so these are the most common causes of sinus bradycardia. Then we got sick sinus syndrome. I don't use this terminology anymore. I rather call it sinus node dysfunction. It means that the sinus node occasionally fails to depolarize. And by doing that, causes long pauses. These pauses can be followed by a rescue bit. That could be sinus, or could be junctional, like in this case. Sometimes it's ventricular. It very depends, usually, on the length of this pause. And this can be functional, if there is an increased vagal tone, or could be structural, if there is a degenerative process affecting the cells at the level of the sinus node. This can be very problematic if the heart rate is, or the pauses are long enough to cause a reduction of cerebral perfusion. And usually we say 5 to 6 seconds. If the pauses are longer than 5-6 seconds, very often they're accompanied by falling and fainting or syncope. We had a very long one lately, didn't we? Like 20 seconds. Yeah? It was very, very long. Then we have the AV blocks. We got 3 different grades or degrees of AV block. The first degree AV block is something that we ignore completely. It's just a prolongation of the PQ interval, so a prolongation of conduction through the AV node, and very often it's associated with a heart rate. So if you drop the heart rate, the PQ interval increases, but it's never symptomatic, so we simply ignore it in our patients. Or we can have a second degree. This can be problematic, especially remembering the 2 subclasses of second degree. One is a class 1, and one is a type 1, and one is type 2. Type 1 also called Wenckebach phenomenon, and is characterized by a progressive prolongation of the PQ interval, longer and longer and longer, and then eventually we miss a beat. In this case is 1, 2, 3, 4 to 1. So 4 prolongation and then a missing beat. This can progress and move into type 2, where we got, every time we got multiple non-conductive P waves, but the PQ interval remains always the same, right? So you see PQ here, identical to this one, identical to this one, identical to this one. Now, depending on the result in heart rate, we may have clinical signs or not. Clinical signs are usually all the signs of bradycardia, or significant bradycardia, lethargy, exercise intolerance, falling and fainting, and sudden death is a possibility, but not very common. And then we move to the third degree AV block that I call the complete divorce. So the atrium ventricles don't communicate anymore. And we got a rhythm where there are 2 completely independent rhythms. One is atrial and one is ventricular. But the atrial beat much faster. So you see these are all P waves here. 1, 2, 3, 4, 5 P waves for every QRS. But they are completely independent. So on the body surface where we record the ECG, you can see the superimposition of these 2 rhythms. So here this P wave, for example, appears within the QRS complex, okay? But that's because of a summation on the body surface. It's not an intrinsic abnormality. And the escape could be a narrow complex, like in the example on the top, or Y complex, like ventricular rescue beats from the ventricles. And finally, we got the atrial standstill, which is, in a way, similar to an AV block, because we don't have atrial activity. So the ventricles, once again, beat independently. They follow their own rhythm, which is called idioventricular rhythm. And again, we can have here narrow complexes as the ventricular rhythm. This is probably originating from the bundle of Yeasts. Or we can have a proper ventricular escape rhythm. Now, atrial standstill could be primary, so if it's a disease of the atrium, and therefore the sinus atrial node doesn't work anymore. We don't have any atrial activity, electrical activity of the atrium, but could be also in response to increased potassium. And if we have, for example, an atrial standstill due to hyperkalemia, like in Addison disease, then it can be easily converted. We just give saline, nothing else, just to dilute the blood and reduce the concentration of potassium. Obviously, you need to treat the underlying cause afterwards, but that's your job, okay? I only work with this little area here. So we send it to medicine after that. Well, I treated dogs with Addison, but it was a while ago. So here we started from 8.4 millimoles per liter with a heart rate of 55 and atrial standstill. And then by giving just simple saline, we went to 6.5 millimoles per liter, still high, but enough to restore the sinus activity 120 beats per minute. So that's how we can at least manage atrial standstill successfully from an ECG point of view. But for all the other bradycardias, how would you manage a clinically significant bradycardia? You can type if you want, or you can take a deep breath, and I move to the... Sergio's not typing anything, he's too tired. Huh? Ha. Right, okay, so we got one. Pacemaker, well done. We can try drugs. Atropine certainly gives a nice kick by reducing the vagal activity, being a parasympathikolytic. But we can't really inject atropine every 3-4 hours, which is the usual time of activity. We can use sympathomimetics like the butylene or phosphodiesterase 3 inhibitors like theophylline. They are short-term interventions. They work because they normally tend to increase the ventricular response rate. So even with AV block, if we give theophylline, for example, we can perhaps move from an escape rhythm of 40 to an escape rhythm of 45, 50, which makes a big difference from a dog completely flat to a dog that at least can lift the head and eat. And we normally do while we wait for the pacemaker. So we organize the pacemaker maybe the day after or a couple of days later, and then we intervene. But otherwise, what we see in the long term with this medication, we had one dog that was on theophylline for a year, wasn't it? Because the carer refused to have a pacemaker, but it's not the best standard of treatment. The best standard of treatment is a pacemaker implant. They've been available for many years. This is the very first pacemaker I implanted 25, 30 years ago. There we go. And so you see, these are also much cheaper nowadays. At that time, we were using recycled pacemakers donated from funeral directors. And nowadays, they are much, much cheaper, and we only use brand new pacemakers. We try to re-sterilize them, but they're all still there in the box. We never use the re-sterilized one. But if we have perhaps somebody says, oh, I don't have enough money, then perhaps we can offer them. Right, a pacemaker will provide a very reliable, consistent rescue of the heart rate and heart rhythm, and the clinical response is always excellent, excellent. And is a standard procedure nowadays, and that's something that we always recommend.